A patient has suddenly noticed tight skin and color changes around her fingers. Please ask any relevant questions and proceed as appropriate. So after introductory part, our focused history should start with when did it start exactly? Is it increasing or decreasing? Is there anything making it worse? For example, exposure to cold environment. Is there anything which makes it better? For example, wearing gloves. Which fingers are affected? Have you noticed any rashes over any other parts of your body? Do you have any shortness of breath, any swallowing problem, any chest pain, any swelling of your legs, or any racing or pacing of your heart, any heartburn or difficulty swallowing in particular? Do you have any red patches over your fingers to check for telangiectasia? Can you tell me more about the color change? Does it become blue? Do you have any joint pain? If the patient is female, always ask for 3 P's, pill period and pregnancy. Do you have any generalized symptoms like any fever, fatigue, difficulty sleeping, any depressed mood, any anxiety, any weight loss? Systemic sclerosis can be a component of MCTD, so also ask about the features of SLE. You have already covered joint pain, fatigue, fever, etc. Ask about any hair loss. Family history is important because all rheumatological diseases have genetic component. So ask about family history, previous pregnancy history, because antiphospholipid syndrome can cause miscarriage. Drug history, previous hospitalization history, and previous medical history and history of any comorbidities are also important. Then do some focused examination in her hand. Check for sclerodactyly, which means thickened tight skin, calcinosis, evidence of Raynaud's phenomenon, digital ulcers, and telangiectasia. Assess patient's hand function. You can check the strength of her hand muscles and tell her to pick up a pen or coin. Look at her face to check for any telangiectasia or microstomia. Auscultate patient's lung to listen to any fine respiratory crackles, especially in the bibasal region, to find out any lung fibrosis which can be associated with many rheumatological diseases. Also check for pulmonary hypertension, that would give you loud P2, right parasternal heave, raised JVP, tricuspid regurgitation, and peripheral edema. You can ask the examiners about the blood pressure and urine dipstick. Systemic sclerosis case can be a very easy case to diagnose during PACES Station 5 test because there are a lot of clinical features of systemic sclerosis which can be easily seen. If the patient is wearing a mask, then ask the examiners, can I remove her mask? Because during COVID time, removing a patient's mask was not acceptable, but at the same time you need to look for microstomia. So ask the examiners before asking the patient to remove her mask. The examiners can ask you which other organs are affected in systemic sclerosis. The answer should be kidneys. Scleroderma can cause scleroderma renal crisis, occurs in 5 to 10% of the patients who present with an abrupt onset of hypertension, acute renal failure, headaches, fevers, malaise, hypertensive retinopathy, encephalopathy, and pulmonary edema. It can also affect lungs, causing pulmonary hypertension and pulmonary fibrosis. Also, it can affect heart, causing pericardial effusions, myocardial fibrosis, conduction defect, and congestive cardiac failure. How to treat a scleroderma patient? For Raynaud's phenomenon, we can give calcium channel blockers such as nifedipine and angiotensin receptor blockers such as losartan. Intravenous prostacyclin, bosentan, etc. are also options if calcium channel blockers does not work. For reflux esophagitis or esophageal dysmotility, proton pump inhibitors can be given. For hypertension or renal protection, AC inhibitors can be given. For skin, joint and lung lesions, we can give steroids or steroid sparing agents like cyclophosphamide. And for surgical options, we have digital sympathectomy, and smoking cessation is also important for these patients. What immune tests are available? For limited cutaneous systemic sclerosis, we can do anti-centromere antibodies, and for diffuse systemic sclerosis, we can do anti-SCL70 antibodies. If it is a component of mixed connective tissue disorder, then we can do a RNP. What are the differences between limited cutaneous systemic sclerosis and diffuse systemic sclerosis? Well, if someone has organ involvement or skin involvement proximal to elbows or knees, or skin involvement in face or neck area, then he or she would be classified as a case of diffuse systemic sclerosis. But if someone has skin involvement distal to the knees or elbow region and no organ involvement, then he or she would be classified as limited cutaneous systemic sclerosis case. Please be mindful that CREST syndrome is also a limited systemic sclerosis, which means calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia.